Hello everyone, you are all welcome. This is the first video lesson from the introductory module on narrative medicine. This unit has an introductory objective through the lessons, the recommended readings, or even the videos or links. The students should be able to recognize the proposals of narrative-based medicine and some of its most important theories. In 1999, the prestigious journal BMJ published an article defending the need to practice narrative medicine in a world dominated by evidence-based medicine. Some years later, in the same journal, the work of Teresa Greenholz and colleagues argued that although evidence-based medicine has had many benefits, it has also had some negative unintended consequences. In this paper, they offer a preliminary agenda for the movement's renaissance, refocusing on providing usable evidence that can be combined with context and professional expertise. The narrative is a very central issue for this renaissance. More than 20 years have passed since the evidence-based medicine working group announced a new paradigm for teaching and practicing clinical medicine. Traditions, anecdote, and theoretical reasoning from basic science will be replaced by evidence from high-quality randomized controlled trials and observational studies in combinations with clinical expertise and the needs and wishes of patients. Evidence-based medicine quickly became an energetic intellectual community committed to making clinical practice more scientific and empirically grounded, and thereby achieving safer, more consistent, and more cost-effective care. 2 decades of enthusiasm and funding have produced numerous success for evidence-based medicine, but also criticisms such as the loss of humanistic treatment in favor of clinical trials also questioned whether findings from average results in clinical studies could inform decisions about real patients. Another aspect of evidence-based medicine's crisis, and yet, ironically, also a measure of its success, is the sheer volume of evidence available. In particular, the number of clinical guidelines is now both unmanageable and unfathomable. Narrative-based medicine was established as an emerging paradigm at the end of the last century, with the publication of a series of works considered to be its foundational corpus. On a first movement of a contesting natures to what they understood as the excesses of evidence-based medicine. The shared thesis was the critique of a clinical practice that made dogma out of the general over the specific, elevated the quantitative over the qualitative, and thrown clinical trials over experience. Summary: a history that threatened to become a history that would do away with all histories. The model of or theoretical framework started from a demystification of the factual and empirical observable world of the clinic to offer space to the subjective world of patient experience, understanding narrative as semiological apparatus that produce meanings and open up the spectrum of evidence to issues such as inner pain, hope, and despair, moral pain, that frequently accompany and often indeed constitute the illnesses people suffer. The original thesis pursues a function of encounter, of bridging gaps. By coming to the rescue of the patient experience, the aim was to build bridges between health professionals and patients, and also to bridge the gap between knowing about the disease and understanding the patient experience. In matters of health and disease, not everything could be measured and evaluated in positive terms. This is very, very important. This is one of the keys. Shortening the distance between knowing the clinic and accompanying suffering. In the context of spiritual care, this will be very, very important. Narrative-based medicine argues for the need to link accounts of illness experience, narrative and their subjective character to primary evidence for clinical practice, but not out of a mere humanistic interest, but because it's understood as a clinical necessity and usefulness. If the objective evidence from the clinic were crucial, the subjective evidence from the experience of suffering were certainly no less crucial. Lipson warned then that for patients the central fact was living with illness, and this meant that illness had to be understood more as a matter of story, experience, and interpretation than as an objective and uniform domain. Some years earlier, Harvard University anthropology and psychiatrist Arthur Kleinman had already argued convincingly for the need to pay greater attention to sick people's stories of suffering. The work of the sociologist Arthur Franks, The Bounding Storytelling, Body, Illness and Ethics, is often quoted as one of the texts on which the first wave of the movement is based. The author describes his personal experience with a serious disease, abounding the body self, our bodily being in the world. Since then, doctors' autobiographical accounts of their illness, their clinical experience or relationship with other colleagues have also grown in attempt to take a narrative approach to the constructions of their knowledge and practices. But of all, attention was focused on the encounter of narrative in the consultation room and the various encounters between doctors and patients, and giving importance to the illness, the version of the illness narrated by patients, their personal experience. Rita Charon, one of the leaders of the movement, defined it as follows: narrative medicine refers to clinical practice fortified by narrative competence, the capacity to recognize, absorb, metabolize, interpret, and be moved by stories of illness. Simple. It's a medicine practiced by someone who knows what to do with stories. I remind here to check the recommended bibliography in these units for further development. This is one of these. The professional-patient relationship is therefore a process of reading. The health professional imagines the situation by trying to recognize the multiple and often contradictory meanings, placing himself in the patient's place in emotional, social, familial, and cultural terms. This is where diagnostic listenings comes into play, the space where the doctor resources intersect memories, associations, anecdotes, creativity, interpretative skills, or allusion to other stories to identify meaning, and thus try to answer, not always completely, the question addressed in the patient's narrative. What is happening to me? Why this is happening to me? And what is going to happen to me? This is a three-stage process. The first one's attention. The clinician caring for a sick person must begin by entering the sick person present and absorbing what can be learned about that person's situation. Now, patients who were to be listening to in active way, oceanically embracing the whole narrative along the lines of what Arthur Clayman had called an empathetic witnessing stance. In the words of Charons, attention should be the most urgent objective on our work. Listening as a form of giving, and the medical clinic could not be a mere monologic interrogation where the patient answers affirmatively or denies question. The habit of closing listening or slow looking, thereby improving their quality of perceptive attention. I ask you to stop here this presentation and read the way Charon captures the kind of attentions that a professional should show and imagine in the context spiritual care, what James called the great empty cup of attention. From attention, we move on representation, representing in language or other medium what we perceive, in many cases writing it down in some form. From attention, we move on to representation. A growing bank of outcome studies demonstrate the consequence of including literary and narrative work in clinical training and practice. Of 18 studies included in a systematic review, this one, of teaching empathy to medical students, 4 studies report an improvement of immeasurable empathy when using narrative intervention. The movement of attention and representation spiral together toward the ultimate goal of narrative medicine, the third step, affiliation. In this, that we are after the authentic and muscular connection between doctor and patient, between nurse and social worker, among children and dying parent, among citizens trying to choose just an equitable healthcare policy. The affiliation extends inward to join doctor or nurses with themselves in a sustained habit of clinical reflection, or to allow the suddenly ill patient to recognize the same self who existed before illness came. Instead of lamenting the decline of empathy among medical students or the lack of altruism among physicians, narrative medicine focuses on our capacity to join one another as we suffer illness, bear the burdens of our clinical powerlessness, or simply together bravely contemplate our mortal limits on earth. I recall here what Byron Good wrote. There can be no illness with a body, but illness is not something that occurs in the body, but in life. Narrative-based medicine forces us to think of illness in terms of interpreted stories, while the accounts of experience, the narrative of the patient, family members, or health professionals themselves were relegated in the hierarchy of evidence. These words advocate for their centrality. For those more interested in this proposal, you can follow the major teaching project at Columbia University. Through narrative training, the program in narrative medicine helps doctors, nurses, social workers, and therapists to improve the effectiveness of care by developing the capacity of attention, reflection, representation, and affiliation with patient and colleagues. Our research and outreach mission are conceptualizing, evaluating, and spearheading these ideas and practice national and international. The proposal lead by Sharon is not the only one. With some difference, which you can see summarized in these slides, it also included within the advocacy of incorporating narrative as a central evidence for the clinic. Finally, I would like to recommend some books that can be used to deeper your understanding of narrative medicine and narrative competence. I also encourage you to review the proposed bibliography to read and another recommended papers and book. This video is just a general introduction to this paradigm, which is not always explained in health science faculty and their programs. Thank you very much. See you next video lessons.